Hello, everybody. This is Dr. David Pascal calling or talking to you from the Pascal Health Institute in gorgeous Cary, North Carolina. I want to welcome all of you to this Facebook Live, whether you are watching it live or watching it recorded. And today we are going to talk about um, what is CRPS and why do people get it, and what you can do about it. So CRPS, complex regional pain syndrome, used to be known as RSD, reflex sympathetic dystrophy. uh, Fairly rare as neurologic conditions go. It's estimated that there are only 100 to 200,000 people on the entire planet that have CRPS, and there are a couple different types that have been delineated. Type 1 is where a person has had some type of trauma. That trauma can be broken bones, sprained ligament, or even surgery, right? All of those are traumatic events, but there is no actual documented nerve damage. That's the most common type. There's about 90% are type 1 CRPS. Type 2 CRPS, about 10%. Those are the ones that have documented nerve damage. Now, what is being documented? Well, we definitely have a sensory issue. We have very high pain that is disproportional to the amount of trauma. So if we sprain our ankle, we're going to have pretty high pain. Usually, if we use the McGill pain scale, most of us in life, we're using a pain scale of 1 to 10. So 1 is mild, 10 is severe. But in reality, we have to have much higher scale because there are things more dramatic than slamming your shin into the coffee table, which some people might say, oh, wow, that's horrible. That's 10 level pain. So the McGill pain scale goes 1 to 50. And so if we have, let's say, a ankle sprain, that's around a 15 on a 1 to 50 scale. If we have a fracture, I think they're putting that around, actually can't recall right now, about a fracture, I think, is up around a 20. We know that childbirth is, or amputation, right, without drugs, someone chops off a finger, that is around a 40, and CRPS is put up there at about a 45, 47. So it's really the highest known problem that, or condition that a person can have in terms of pain. In practicality, when I talk to patients with CRPS, they are using like a 1 to 20 scale. So, 20 being at the very limit of tolerance. And most of the people that I've seen with CRPS, they are on the 1 to 20, they're saying that they're in that, 17 to 20 range. So we definitely have a sensory issue, perception of pain. We're going to have a skin issue in a couple different ways. One is there's discoloration, very common for the skin to turn red or orange, or even blue or purple, and this can come and go or stay that way. Another thing that we'll see with the skin is swelling, right? Edema, very, very common to see with people with CRPS. And hair growth. Um, Hair growth in a place where they normally wouldn't have hair growth. And then it's also very common for people to lose hair where they did have hair. So we will definitely see that. We're going to see a motion change because of that swelling. Then when you swell up a joint, then it becomes more difficult to move. Also, pain is a big limiting factor for motion. And Yeah, and muscle weakness, right? So as we become more and more sedentary, people will become weaker and weaker. I see a lot of CRPS patients where the CRPS is in their feet, so they can't even put their feet down on the ground. So then they are in a wheelchair to move around. Well, now they're not moving their legs, so then their muscles are going to atrophy. So we're going to get motion change from all those different ways. In terms of the official diagnosis of CRPS, we get a lot of people reaching out to us asking, and there is no definitive test for CRPS. We have some criteria. There's the Budapest criteria where they're looking at those things that I just mentioned, the sensory issues, the skin issues, the swelling, the discoloration, the hair, the loss of motion, all of these things. And there are two ways to look at that. One is the symptom that the patient is experiencing, right? Pain. I can't tell how much pain you're in. I can see swelling, but I can't see pain. So, um, but you can. So we have the symptoms and then the sign. So I can see discoloration. That would be a sign of CRPS. And typically, we want to, if we're following the Budapest criteria, they're looking at you have to have at least three of these things, right? The sensory issue, the skin issues, the motion issues, all of these things, and then at least one sign in at least two different categories. So you might have the swelling and the extra hair, or you might have temperature change is another thing. This is a symptom where people lose their ability to have normal sensation. So they can't tolerate something that's too cold or maybe too hot. Some people can't tolerate either. But it's very common to just have one thing where cold, like even slightly cool water feels like it's burning, or something warm can feel like it's burning the person's skin that has CRPS. So we're looking at least a couple of those signs. So that is the main way that CRPS is diagnosed is with the Budapest criteria, but there are some people that fall outside of that. There's no X-ray that can be done, MRI, nerve conduction study, blood test that is going to be able to give a person a diagnosis of CRPS. So it's primarily these signs and symptoms, primarily from the Budapest protocol. All right. The next thing is why. Why does one person get CRPS and another person not? You know, that comes back to me, people are predisposed. They're just predisposed to having that happen. And I have found that most of the patients that come to me with CRPS, they have not responded well to treatment. And most treatment in Western medicine is pain based because CRPS, the number one symptom, is this off the chart pain. And so if you go into the hospital, you go into a medical doctor and you say, I have off the chart pain, then once they, rule out any type of objective cause for that pain, like a giant steak knife in your foot or a fracture, then they are going to try to address that with medications. And there's, varying levels of medications, all the way from super mild over-the-counter things to very dangerous prescription drugs that are trying to stop the pain nerve from transmitting the pain signal from, let's say, your ankle to your brain. And so that's the first line of Western care. If that doesn't work, then they're going to try to do more of a mechanical block of the pain signal. So that can be a nerve block at where the nerve enters the spinal cord. They can do that with a mechanical way, like with a needle, or they can do that with a drug. They can inject something that's going to try to block that transmission. And if those aren't working, they might even try to cut the nerves, ablate the nerves, right? They can use different machines that basically are like a soldering gun that will fry that nerve, that sensory nerve, so it can't carry a signal anymore. Or a spinal cord stimulator where they're actually putting a little electronic machine into your body, under your skin, attaching it to the nerves to try to block the spinal cord from carrying those signals up to the brain. Those procedures, whether chemical or mechanical, only help 20 to 30% of the people with CRPS. The other 70%, doesn't matter how many drugs you take, how many nerve blocks, nerve ablations, spinal cord stimulators you do, there's no change. So what I have found, the reason why that is the same reason why people are getting CRPS, is that there are multiple factors that were pre-existing, that were already there, usually almost from birth, and the person is just a ticking time bomb. So what are those pre-existing things? Well, usually the person has a very sensitive nervous system. Even as a small child, we found that a lot of these people with CRPS were sensitive to smells or sound or taste or texture. So they already have a heightened nervous system. The next thing that we see is a hormone imbalance. The vast majority of people with CRPS are female, maybe as much as 90% are female, and the majority of those women are teenage girls. And the other largest group are perimenopausal women. So with all of those people, and with the men that we see, the rare man that comes in with CRPS, they are exhibiting like very high estrogen levels, low testosterone, or effeminate type qualities due to hormone imbalance. So we have someone that's already a hypersensitive person. We have someone with a hormone imbalance. Usually we see a high number of either sensitivities or allergies in people that have CRPS, and even people where the next level above that is that they have some type of autoimmune disease, right? There are tons of autoimmune diseases, and they could have a thyroid issue like Hashimoto's. They could have a colon issue like Crohn's disease. It could be in their joints like rheumatoid arthritis, but it's very, very common for us to see some type of autoimmune disease in people. And of course, we do have a neurologic issue, right? The person is perceiving pain, but from my experience, it's not the peripheral nerve, because if it, let me back up and give a definition of peripheral nerve. Our nervous system is kind of divided into two parts: the central nervous system, which is our brain stem, and our spinal cord, and then the peripheral nervous system. Those are the nerves that are exiting off the spinal cord, going to all of our muscles and organs and skin. Skin's an organ, but so that is the outside or peripheral nervous system, and that is the part that Western medicine is primarily trying to address. When that doesn't work, then what we find is that the person's still perceiving pain, but that pain is not coming from the periphery. That pain from the peripheral nerve being stimulated. And here comes our son again, giving me a little glowing effect. So we'll just go with it on this call. Maybe try to take off some of that, but it's not going to change too much. So we find that the pain perception part of CRPS is actually brain generated. And I've talked about this in other talks earlier, But basically, when we get that sudden trauma that is the trigger for our CRPS, the brain gets flooded with pain signals. And in an effort to get some type of balance, the brain will try to inhibit those signals, turn those signals off. And here goes my phone here. We'll try to stop this here. Sorry about that. And I will see if I can come back. There we go. Technical difficulties sometimes occur when we're live. So, trauma occurs, the brain starts getting flooded with pain, brain inhibits or stops those pain signals. And it doesn't just stop the pain signals, it ends up stopping all the other sensory information that's coming in, like temperature and light touch and vibration and pressure. And that all happens in an instant. Then the brain goes, hey, wait a minute, we need that information because we need the sensory pain information because pain tells us something bad is occurring, and that's our motivator to change our behavior, get our hand off that burning stove or whatever it is. But the brain's already inhibited the pain. So what it does, and the other sensory signals. So it says, all right, I am going to, and it can't totally stop it, but it stops as much of it as it can. It says, I am going to now interpret these other sensory information that's coming in, the light touch and the temperature and the vibration, the pressure. I'm going to interpret that as pain because pain is the most important thing for me to know. So now what we have is the brain itself is generating the perception of pain to us, which is why when we try to block the peripheral nerves, it's not working, right? Because it's the brain itself that is generating pain. And to this end, that's why the MDs are going to try to use a drug like gabapentin to try to disrupt that signal. I did just see a study yesterday that gabapentin is really creating some terrible side effects that can be permanent. And I've seen this in patients that come to me, the ones that have been on gabapentin for a long time. They tend to be much more difficult to move into remission because of how it's changing the brain chemistry. So I hope that this gives you a little more clarity on what CRPS is, why people get CRPS, and the last part is how to address it. Because CRPS is multifocal, it needs to be addressed multifocally. You need to have a program that normalizes or returns the hormone levels to normal. That can reset the immune system to address those sensitivities, allergies, and the autoimmune component of CRPS, to try to address the brain tissue itself so that the perception, to try to return the brain's perception of sensory information back to normal, to reset it back to normal. So those are all the different things that we do in this office. And there's also a mental component, because when you're in pain, such severe pain for so long, then it's going to have an emotional impact as well. And so we have part of our program to address that. So at Pascal Health Institute, one of the reasons why we have such a high success rate, helping people with CRPS moving them into remission, is because we are changing their immune system. We are changing their nervous system. We are rebalancing how the nervous system is perceiving pain, and we're addressing the mental components and the hormone imbalances. So we have this multifocal approach. When you address something that has 5 or 6 different causes with 5 or 6 different treatments, then you're going to get a much better outcome. If you have any more questions, please feel free to reach out to me. You can call, text, email, you can always set up a Zoom call for no charge. I would be glad to talk to you personally, or we can do something as simple as just exchange emails. But I'm here to help, whether you become a patient or not. My mission is to help people with as many people as I can with CRPS get into remission. So to that, I wish you all the best year that you've ever had coming up. Here we are at the beginning of 2026, and this is the year of change. So if you're looking for positive change, then reach out to me, and I'd love to assist you.